Hello, my name is David Turnberger, and this is my uh, peer-to-peer intubation attempt number 5. First thing that I want to do is gather up all of my materials, so make sure that I have a BVM with a mask, I have capnography, my ET tube, which has a stylet and syringe. I want to go ahead and make sure that the ET tube is able to inflate the bowl. I also want to make sure that I have a properly fitting one, so for your standard size adult, you want about a 6.5 to a 7. This is currently an 8, which an 8 can be used for more for your larger patients. And then for pediatrics, it's going to be significantly smaller. I also want to make sure that I have a stethoscope, suction device, and my laryngoscope, OPA, and proper PPE. So I currently have my patient on a high-flow nasal cannula to help with pre-oxygenation. I'm going to go over, manually open the airway, inspect the airway to see if there's any secretions. If there is, I will insert my rigid tip catheter, plug the hole, suction for no longer than 10 seconds on my way out, re-inspect the airway, come on over, measure my OPA, insert my OPA, and then I will put my patient on an SpO2 monitor, and I will attach my BVM to oxygen, and then I will ventilate my patient at a rate of 10 to 12 times a minute. And then I will monitor their SpO2 to make sure that they're getting above a 94% in O2, and if they've had enough time to be able to pre-oxygenate, I will get ready for intubation. So I will remove my OPA, re-inspect the airway one more time, and then I'm going to put my patient in a sniffing position, grab my laryngoscope, make sure that the light is turning on. There we go. And then I'm going to hold it in my non-dominant hand, displace the tongue, and lift the mandible. Then I'm going to there we go. There we go. Going to inflate my cuff, remove my syringe, remove my stylet, and then again to start ventilating the lungs, yet again at a proper rate of 10 to 12 times a minute. I'm also going to be monitoring for signs of hypoxia. I can also auscultate my lungs and my epigastrium to make sure that I have proper ventilation as well as proper placement. And then I will adjust the tubing as necessary to make sure that I am getting adequate ventilation. Once that has been done, then I will go ahead and add a secondary confirmation device such as capnography. Go ahead and put that in my monitor, go back and continue to ventilate my patient, evaluating capnography, also for any signs of hypoxia, and check over my SpO2 monitor. Once I have done all that, I will continue to evaluate my patient for any changes in patient condition. So say if my patient did have some secretions end up in the ET tube, then I would want to make sure that I grab my flexible suction catheter. So I'm going to say that my stylet is my flexible catheter. So I'm going to go ahead, insert that into my ET tube, then I will go ahead and plug the suction port so it'll allow it to start suctioning, slowly suction on my way out, recheck ET tube placement, and then I will go ahead and continue to ventilate my patient, monitor for signs of hypoxia, I'm going to check their capnography as well as my hypoxia, and then evaluate for any change in patient condition.